Good evening, ladies and gentlemen. Welcome to the inaugural regional clinical meeting conducted by the Peradeniya Medical School Alumni Association. I'm Duminda Yasaratna, Assistant Secretary of PeMSAA, and I'll be moderating the event today. And today's topic is a very relevant and a very current topic on COVID-19, addressing the conundrums of the general practitioner. And today's session will be jointly organized by PeMSAA with Rathnapura Clinical Society. So before introducing our guest speaker today, let me take a moment to invite another very important person to speak a few words to the audience. That is none other than our current president of PeMSAA, Professor Tushara Kudagammana, who has in fact conceptualized these virtual regional meetings among many other novel educational and social activities organized by the PeMSAA over the last few months. Professor Kudagammana, it's over to you for a few words for the audience, please.
Thank you, Duminda. Good evening, everybody. So let me welcome all of you on behalf of PeMSAA, that is Peradeniya Medical School Alumni Association, which is now jointly organized by PeMSAA and Rathnapura Medical Society. So PeMSAA is the oldest alumni association of the medical schools of this country, and we are 30 years old now. And we are a very powerful organization with overseas chapters in USA, UK, then we have Australasia and Bhutan. So PeMSAA is primarily concerned with welfare activities of medical students of Peradeniya, but also we conduct many CME activities for medical officers, not only Peradeniya alumni, but medical officers in general. We also conduct many soft skills development programs, and about 1 month ago we had a very nice session on how to dress and dress code and etiquette, which was well attended. And I invite all of you to log into our website, www.pemsaa.org.lk, where you might find things that interest you. And also, I would like to invite Peradeniya alumni who have not joined hand with us yet. Please again log into our website, and there you find easy means of how to get membership, and so that you can help our students and also help your colleagues. So again, Duminda, thank you very much, and I would like to thank Duminda and Dr. Vasana Kiradena and the team for organizing this event along with Dr. Neranjan from Rathnapura. And let me hand over again to Dr. Duminda Yasaratna, who is going to moderate today and to introduce the speaker and the topic today. Okay, over to you, Duminda, and have a nice session. Over to you.
Thank you, Professor Kudagammana. So today's speaker actually is not a stranger to most of you, Dr. Neranjan Dissanayaka. He's the current, he's working as a consultant respiratory physician currently at Teaching Hospital Rathnapura. And also he's the president of the Rathnapura Clinical Society. He's a council member and a past assistant secretary of the Peradeniya Medical School Alumni Association. And also he's a undergraduate and a postgraduate trainer of Postgraduate Institute of Medicine. Dr. Neranjan also is serving as a council member and also as a past he was a past secretary of the Sri Lanka College of Pulmonologists, and also he's a member of the subspecialty board in respiratory medicine. Dr. Neranjan is a very active resource person in most of the forums and most of the seminars organized by the College of Pulmonologists and many other international forums. And before coming to work at Rathnapura, he has been the consultant respiratory physician at Novovex and also at General Hospital Badulla. So he has a lot of experience behind him. So without taking much of his time, I'm inviting Neranjan also to Ranjan to this podium. Neranjan, good evening to you.
Yeah, good evening, Dumita. We are having actually an interesting match going on. Sri Lanka is down with 4 wickets now, and with about 74 runs on the board. So anyway, so
Hi.
it's I think things are a lot much interesting in the field rather than in the COVID field. But anyway, I think I would like to thank Professor Kudagamana as well as the council and especially Dr. Vatsana Kilidana for initiating these regional meetings to introduce PeMSAA into the peripheral hospitals as well as improving the continuous medical education activities around provinces. And today, I think we will be conducting this lectures basically as a discussion to highlight some very important aspects of about COVID. And when we talk about COVID pneumonia, during the past few years, past 2 years, almost the humanity has brought down to its knees by this small virus. And we actually didn't think that it was possible for a virus to do this, except in 1918, where we had a huge pandemic due to influenza. But with the scientific improvements, we thought that we have tamed most of the infections, but nature brings up its head in many ways. So COVID is a very interesting and a challenging organism, and it is bringing out challenges on a daily basis. And when we think that we have gone through one of the waves, we get another wave due to various factors coming into play. And I think it's very important that we think about COVID onto uh, how to face the challenge about COVID and to how to face the challenge about COVID. And when you are facing the challenge of about COVID, I think the general practitioners are the frontline doctors who are working in the peripheral as well as in the central areas of our country. And most of the time, they are the first contact of medical personnel in the hospital as well as in the medical field. So we thought that we should talk to them directly and to help them to sort out some of these problems that they might have to face because of this COVID pandemic. So we have structured this discussion according to a plan, and Duminda and myself will be able to conduct it within the next 1 hour. And hopefully, if we have problems and questions, we can then answer it accordingly. Okay, over to you, Duminda.
Yeah.
Yeah.
Yes. So yeah, that's a nice introduction, Ranjan. So for the audience, so if you have any questions, you can use the chat function during the seminar, during the discussions, or uh, I suppose you can raise your hand, and we might also, if you want to ask a question straight away, you can raise your hand, and we can give you an opportunity as well. Uh, so to start the discussion, so just today I was looking at the statistics, and there have been 225 million infected people worldwide with 5 million deaths. And Sri Lanka is also, now there are 500,000 cases with 11,000 deaths. So we thought initially that we have understood the virus, but then it always gives us surprises. There's again new strains coming. There are changes in the picture, and we are always learning. So it has been a never ending learning exercise for most of us. So about the symptoms, the how they present, Niranjan. So there has been some changes in the recent past. Uh, can you please elaborate
Yeah,
on that for the audience?
that's yeah, that's the interesting thing, isn't it, about this virus? Now, when it came into play around the late 2090s, 19s, what we saw was that the majority of the symptoms were because of the cough, the fever, as well as it usually progress into shortness of breath, difficulty in breathing. And then later, when you have severe disease, these patients develop severe dyspnea and then were admitted to the hospital. But majority were asymptomatic, but a significant proportion of the symptomatic patients developed lower respiratory tract symptoms, mainly cough and shortness of breath. And when we analyze the clusters of symptoms, we can actually have several clusters of symptoms that were coming because of COVID. Earlier it was cough and shortness of breath, but later we understood that there are other symptoms that can be attributed to COVID, and one of the other clusters were the abdominal symptoms. Some of the patients, and I think most of us will agree that the patients had abdominal pain, loose stools were another important, and vomiting were another important group of clusters of symptoms that patients came to us. And in the early stages, most of these patients were non-suspectedly sent to surgical wards, and these patients were later diagnosed of having COVID. Fever, obviously, it was a very common symptom, and then followed by body aches as well as muscle and body aches like dengue. So sometimes they were mimicking dengue as well. And an interesting finding was that the loss of smell, which were described especially in the European countries earlier, but later it with the Delta variant, it became as another prominent symptom. So basically what we had was the symptom. When you look at the symptom analysis earlier, it was basically lower respiratory tract symptoms with fever, cough, and shortness of breath. And there were the abdominal symptoms with abdominal pain and diarrhea and vomiting, and the muscle aches, which were rather common with any viral illness. And one of the important factor was the loss of taste or smell. But there is an interesting turn of events now, because most of the people are now being vaccinated. And when we look at the this is UK data last September. So we can see that this is the blue line is the people who were all having COVID pneumonia. And this red line is of a concern. This is the number of people who are fully vaccinated and now getting COVID, symptomatic COVID. So when you look at this, it is almost like a parallel to the non-vaccinated, the total COVID patients. The vaccinated people are also getting COVID to a certain degree. And what we see in this vaccinated group is two important differences than previously. One is that there is a change of the demography of patients. Now, earlier it was mainly the elderly people, the middle-aged, more than 40-year group were significantly affected. But now we see that, especially because most of the non-vaccinated group are less than 30 years, we see that it is more common in children, adolescents, as well as in young adults, maybe because they were not vaccinated. So there is a significant shift of the demography of patients who are presenting. And at the same time, there's symptom presentation, especially in the patients who had vaccination as well as in children. Now, what we see here is that, so just give me a second. Now, what we basically see here is that, now, these were the commonest 5 symptoms that were presented in that cohort of in the United Kingdom patients who had COVID, right? So now you can see a marked variation from the lower respiratory tract symptoms to the upper respiratory tract. So runny nose and sneezing and headache, we know that it's very common in any virus. And at the same time, it is very common in allergic rhinitis. And sometimes these patients mimic rhinitis, an episode of exacerbation of rhinitis due to allergic rhinitis or upper respiratory viral infection, regular rhinovirus infection or a metapneumovirus infection. So now, sometimes, especially in the general practitioner level, we might be a little bit, deceived that this might not be COVID. Right? So this might be a simple viral infection. This might be a simple upper respiratory infection or allergic rhinitis, especially if the patient has a history of allergic rhinitis. We might think that this patient had rhinitis rather than a COVID infection. But I think it's very important to note these 5 symptoms, because now our population, almost about more than 10 million of our people are vaccinated at the moment, fortunately, because of the drive of the government as well as the health institutes. So we have to be concerned about these symptoms coming in children, adolescents, as well as in patients even who have been vaccinated. So in a patient who has no past history of allergic rhinitis or rhinitis, coming with sneezing, runny nose, and headache, our differential diagnosis, one of the first should be COVID, because patients will come that, and especially we can diagnose, if you can diagnose this patient early, then we can take the appropriate preventive mechanisms rather than allowing it to spread like haywire and wildfire. And especially because we are now planning to open up the schools as well, and because the young adults, young children that were more than 12 as well as adolescents will be coming into schools and institutions, especially educational institutions, we have to identify these group of children, especially first with symptoms, even when they are vaccinated. And ideally, I think we should isolate them early after diagnosing. So for the general practitioner as well as the OPD doctors, I think it is a very important thing to identify that now the symptoms might change. They might not have cough, shortness of breath, and wheezing sometimes, but they will come with a simple sore throat, simple sneezing, headache, and a runny nose, and loss of smell. So that is a very important change of symptoms that we have, Dominda. So I think it's a very important thing that the general practitioner, as well as most of our doctors, should be concerned about.
Yeah, because now, in fact, we see a lot of patients presenting with these rhinitis symptoms these days, and
Yes.
also the patients also in the back of their mind, they have this question whether this can be COVID, whether this can be COVID. And so, and also we are approaching the end of the year, and we'll be approaching the usual seasonal influenza periods also in the coming few months. So it's going to be a challenge for most of us. And most patients are now aware about these testing facilities. They know about rapid antigens, they know about the PCR. There's a lot of advertising going on, they're commercializing. So in a general, for the general practitioner, so how would you advise to choose which testing that we should go for, and they should recommend for the patient?
Yeah, now to be honest with you, now actually we are in a phase where now in certain countries now where they are thinking whether to stop investigating asymptomatic patients completely. Screening process, they are planning to sometimes completely go out of it. For example,
Yeah.
Germany is planning to stop offering free antigen test for the population, and even in UK they are now checking the symptomatic people only rather than the asymptomatic and for the screening process. But anyway, I think when we are looking at it in a general practitioner's perspective, I think we have to know a few things about how to investigate these patients. One of the most important thing is, now this slide summarizes most of the two basic methods of diagnosing COVID pneumonia, and it has its pros and the cons. And when we look at what we call now, there are two ways basically of diagnosing the COVID virus. One is that identifying the subunit of proteins that are there in the capsule. That is what we do in the antigen tests, and where you can identify certain antigenic components of the viral capsule. And then we can identify specifically whether there are elements of nucleic acid of the virus in a specimen that we obtain. And now I would like to, now, as you know, we call the RAT, or rapid antigen test. It's a very, very easy test to perform, and anyone can actually do it without any significant issues. Reading is easy. It's almost like reading like a pregnancy test. But delay in a reading might cause false positive results. So it should be read in about 10 to 20 minutes after the process. But we have to be, when you are interpreting it, sometimes we might have to be a little bit careful whether to be it's positive or negative. But rapid tests are rather cheap as well compared to the PCR, and it takes less time. It takes about 20 to 30 minutes to get the results. So if you have, in a general practitioner's perspective, I think one of the most important investigations that we have in our momentum is the antigen test that is almost freely available in the private sector as well as in certain hospitals as well in the government medical sector. But I think we should understand its limitations, especially thinking about its usefulness. Now, I would like to, I think you can see my arrow here. Now, this is basically the viral load in the y-axis, and in the x-axis, you have the days of exposure. And you can see that the viral load gradually increases in a person who is being after being exposed. The viral load will gradually increase and it will peak up, and then later it will come down to 0. So when we look at the usefulness of the rapid antigen test, it is basically during the symptomatic period. So if a patient is having symptoms, that means the patient is having a rapidly proliferating viral load, a significant amount of viral load in the area that we are checking. So we can check in the nasopharynx, which is the currently recommended area to check it. Oropharynx is less sensitive in most of the people. Sputum is actually highly sensitive, but we don't recommend it because it can generate a lot of aerosols. And bronchoalveolar lavage is the best if you can do, but it is not very recommended. You don't have to do a BAL to diagnose COVID pneumonia. But anyway, so if you are taking the nasopharyngeal sample, it should be taken from the posterior aspect of the nose, not from the throat. And usually it has a sensitivity, a significant sensitivity if the patient is symptomatic. So if it is positive, most of the time, we can say that conclusively that this patient is most likely having COVID pneumonia. And except for that, when we have a delay in reading, there's a possibility of having a false positive, and it has been documented. But one of the most important thing is that, especially when the viral loads are low, especially in the early stages, and when the patient is sometimes mildly symptomatic or asymptomatic, or when the patient's symptoms are progressing, and after about 7 to 8 days of illness, sometimes because our immune system comes into play, and the virus will migrate into the lung, and the immune system will come into play, and most of the rapidly proliferating viruses might not be found. Hence, the antigen will not be found in the nasopharyngeal and throat area. There you might have a false negativity, even when you have COVID pneumonia. So there we have to be very careful to understand that even when the rapid antigen test is negative, there can be two possibilities. This can be a true negativity, but there are two possibilities that we have to always think. One is whether we have done the RAT too early, especially in the asymptomatic or early symptomatic period, or whether we have done the RAT too late. Hence, it is very important to look at the symptoms of these patients, the duration of the contact, as well as when we are thinking about this analysis, and rather than falsely reassuring the patient, sometimes we might have to bring them back, or if we are highly suspicious, then we might have to go for a PCR test to confirm the diagnosis. So it's an easy test to be done, available freely, less expensive, less cumbersome to perform. You will get the result in very, very short time. But the limitation is that it is a better investigation to do in the symptomatic period, right? But in a patient who is having early disease or in a big bit of a late disease, you might have a false negative value. Hence, 100% you can't exclude having COVID, especially if the clinical symptoms points towards COVID. So about the PCR, where we detect the viral ribonucleic acid RNA, this is a nucleic amplification test that we usually do. There are point of care PCR tests that are available in some hospitals. I know one is available in Peradeniya. I know it gives the results in about 2 hours, but most of these PCR results might at least take about 24 to 36 hours to come. Hence, there is a delay. So especially in a patient whom you are suspecting, it might be a little bit of a delay, and the expense is more when you conduct it, especially in a general practitioner's way. When you do it in the private sector, sometimes the patient might not be able to afford the price of this PCR. But the important thing is, one thing is it is rather sensitive even in the early stages, and it will be sensitive in up to about certain late detection as well. But here also, one of the important things about the PCR test is that we have to look at the CT values, right? The CT values indicates the initial amount of nucleic acid that was there in the sample. So if the initial amount of nucleic acid was low, you will have to have increasing amount of cycles to be conducted to detect the RNA component of that virus. Hence, the CT value will be high. And so forth, that we are saying that if it is more than 30, some people might think that it is even non-infective as well. But anyway, so a higher CT value might indicate that the viral load is low, right? So, but does it indicate late disease only? So we might think that, okay, he had this virus and now the CT value is more than 30. Probably this patient is now going into the recovery and he will be better in about few days because he didn't have any problems. But the important thing is, even in the early stage of the disease, especially in the mildly symptomatic, asymptomatic area, especially if we do it in a contact with a suspicion, we might have still a high CT value because you might have still a little bit of small amount of RNA or nucleic acid amount in the nose. So it will take a little bit of time to proliferate and get the reduction of the CT values in like 1 or 2 days. So a high CT value in a PCR will not only, it will not exclusively indicate that he had the disease, now he is recovering. So it might be a sign of early infection as well. So you have to think about whether this person had symptoms, the duration of the symptoms. For example, if this patient has a contact of COVID about 15 days back, he had a mild fever about 3 days, and now the CT value comes about 30. Yes, we know probably this is the case. But if the patient is mildly symptomatic, or asymptomatic and you have done a PCR, it is positive and it is 30, you can't actually think about reassuring the patient that this is early disease, this is late disease. So ideally, then we might have to repeat the PCR in about 48 hours to see whether the trend is going upwards, that is increasing. Our CT value might say that this patient is having a recovery phase, and the dropping PCR CT value might say that this patient is having basically active disease that is developing. The importance of identifying this and when we are interpreting is that one thing that especially if it is in the early disease stage, especially in a high-risk patient, which we will be discussing later, we have to be careful because this patient might deteriorate during the next few days, and at the same time he will be infective during the next few days, even though the CT value is high. Right. So those are the things that we have to think about. So in summary, rapid antigen test is easy to conduct. It gives the results very rapidly. It is less expensive. And especially in the symptomatic period, it gives us a good result, especially if you do it in the nasopharynx in the appropriate way. But early in the disease, as well as in the late in the disease, after about 7 to 8 days, you might have a false negativity in these patients. So in the PCR, expensive, takes a little bit of time, but more specific and sensitive as well if you take the sample in appropriate way. But when you're interpreting a PCR report, always look at the CT value. And the CT value, if it is low, about 15, 12, then we know that it is this patient is in the active disease phase, and he is in, he has the possibility of infecting another person. So we have to be very careful about that patient. But if the CT value is more than 30, still we have to be very vigilant about this, especially considering the symptom analysis of the patient to see whether this is early disease or late disease, and hence we might have to act accordingly before reassuring the patient and sending home. So those are the two important things, Dominda, that we actually have in Sri Lanka at the moment, as you know. And there is the antibody test that we have, which usually looks at the immune response. And in certain hospitals, certain institutions, we have that antibody test as well. But it will tell you whether you have a past infection. So in the diagnostic aspect, it will not be very useful. But if you want to know whether you have been actually infected, but even now, because most of us are vaccinated, hence having a high antibody level will not tell you whether you had an infection or not. So these are the two most important things that we usually do.
Yes, Neranjan. And I think that is more relevant to inward settings as well, because it's not that uncommon. We see patients with the high CT values in very acute stage, and they are developing pneumonia in the next few days, especially
Yes.
the population being vaccinated.
Yes.
So with people having low viral loads, but still going into acute pneumonia. So it's not uncommon. So I think that is the same reason in the discharging guidelines also. Now the MISI guidelines, they mention CT values only if the patient is asymptomatic, and you don't consider CT values if the patient is symptomatic. So I think that is very good explanation that you gave. And also, just to, if I may add something to that discussion, people also have a query whether with the new variants, whether this PCR is working or not. And just to clarify on that, like, because now we know that there are various of variants of interest and also variants of concerns. Like, variants of concerns are when the transmissibility and the disease severity of that particular variant is high, so you term it as and name it as a variant of concern. So all these alpha, beta, gamma, and delta, all these are variants of concerns. But if they evade the diagnostic testing, there's another name uh, that is given by the CDC, that is variants of high consequences. So we do not as yet have any variant of high consequence. So far, according to the available evidence, all these variants, they are still could be detected by the available testing. Am I right, Neranjan?
Yeah, I think it's a very important point that you brought about, and we have to be actually vigilant, isn't it? Because we have to have methods of identifying the genotypes or genetic analysis of the various types of viruses, so that we will identify it early as much as possible, and we have to prevent it from coming into Sri Lanka, or else we might have significant consequences. At the moment, the currently two tests detect most of the
Yes.
viruses without any significant issues. Yeah.
Right. Now, so we might ask the patient to go and get a test done, but most of the patients, if they are asymptomatic or mildly symptomatic, so they know that, well, you have to go to an intermediate center. So patients do not want that. Even private quarantine is very expensive. So patient prefers to stay at home, sometimes even without testing. So, and we know that this patient is not going to get tested, even though we advise the patient that this is most likely COVID. So,
Yes.
in your opinion, which patients that we need to highlight that, yes, you must go and get this tested because it's not good for you.
Yeah.
You might be asymptomatic now, but
Mm-hmm.
you are at risk. So, do you
Yes.
have any
Yes.
recommendation?
I think we all know that that's a very important message that we have to give, and especially by the general practitioners to the patient as well. As you said, some people are reluctant to do the PCR because of the expense, and sometimes people are reluctant to do it because of social reasons. And we get daily patients who had a COVID patients in their house. They have been diagnosed with a rat positivity. They are at home. Then about 2 to 3 days later, the other people develop symptoms, and they stay at home without getting the rat or the PCR done. And they say that, Dr. Mata COVID tibba venna puluwa. Right? So that way, those patients comes in about 2 to 3 weeks to us, saying that now they have a little bit of a cough. So that attitude is there in our patients, probably because of the stigmatization as well. So they don't tend to diagnose them with rapid antigen as well as even the PCR to a certain extent. And even after that, even after knowing that they have COVID, some people are further reluctant to come into hospitals and healthcare settings, because they think that they might be stigmatized. And the second thing is that they think that they can stay home and take care of themselves, so that they will be better in about few days. But in most of the instances, that might be the case. But I think we have to stress several groups need significant close monitoring. And as the general practitioners, I think we have to explain to the patient the gravity of this problem. So one of when I think you will also agree, because we are actually seeing a lot of COVID patients in our hospitals, and as pulmonologists, basically, anecdotally, and in our district, the Rathnapura district, we have actually identified 5 main groups who tend to have poor outcomes, critical illness as well as death. So one of the major important groups that we had is uncontrolled diabetic patients. And I think you will agree that most of our patients, we have about a diabetic population, about 10 to 12% in the rural areas, sometimes going up to 15 to 20% in the urban areas. So if a person has uncontrolled diabetes, I think we have to be very careful, especially if the patient has symptoms of COVID. It is always important to stress the need of correctly identifying the cause as COVID, even by doing a RT-PCR or the molecular test to detect antigen. And then if it is positive, we have to advise them early to come to a healthcare institution, so that they can be investigated and looked after properly, especially in the early stage of the disease. The second group that we have seen poor outcomes in our setting is that the renal problem patients who are on dialysis, or who are not on dialysis, who have been undergone renal transplants as well. So those three groups of patients who have nephrology-associated complications, chronic renal failure, who are on dialysis or not on dialysis, on management, or patients who have undergone renal transplant, we saw a poor outcome in those group of patients, and unfortunately some of them succumb to their illness even after about 5 to 7 days, or sometimes even 20 to 30 days spending in the ICU and HDU care. The third group that we had struggled to improve is the obesity group, right? For unfortunately in Sri Lanka, we have a significant amount of overweight and obese group of people, and they tend to be in their 40s to 60s age group in most of the time, and we have young people as well coming with morbid obesity, and these group of people also have understood that we have a poor outcome, and sometimes we find it very difficult to manage, especially even in the ICU care for proning and giving the generalized care. Also, we find it difficult to manage these patients. So these three groups, especially in the normal population, I think we have to be very careful, especially in our Sri Lankan context, to identify these patients early. And because as a general practitioner, we will know that this patient is having poorly controlled diabetes, with probably nephropathy and retinopathy, neuropathy, and sometimes they might, we know that the HbA1c is about 9, 10, so they are reluctant to take insulin. So these are the type of people might have a poor outcome. So we have to especially advise this patient to at least go into a healthcare setting, get the initial investigations done before assuring them so that they will be okay. And the other group that we have a concern is about the pregnant people, pregnant ladies, who tend to have a poor outcome, unfortunately. And the other group of people, especially, is that the people who are having other chronic disorders, right? So those are the groups of people that we are really concerned. That doesn't mean that we are neglecting other chronic diseases as well, but especially these patients, I think we have to be very careful. And fortunately, the respiratory people, especially the asthmatics, have not found to have a high mortality or morbidity. But certainly if the patient is having end-stage fibrosis or COPD, they have a higher risk of dying because of complications. So I think these are the groups: elderly group, more than 65 years of age, diabetic comorbidity patients with poorly controlled diabetes, morbid obesity, renal impairment, pregnancy. We have to catch these patients early and then do the appropriate investigations without any significant delay.
Yeah, I think that's a very important observation. It's not only in Rathnapura, I suppose. I think throughout the country. Even we see a lot of young obese patients. Even right now, I think we have about a couple of young obese patients in our ICU. We are struggling with them. And as you mentioned, diabetics, uncontrolled diabetics, and especially we have lost a lot of renal patients in our setup as well. So I think it's a very important observation and very good advice for the general practitioners, so they can advise these patients with some extra effort that you have to go and get tested, and you might need admission and you may need some intense monitoring. So for the other patients who are getting quarantined at home, so there are so many patients right now. So what are the alarming features? So what they should be vigilant of? Any symptoms, any signs that they should come out with and seek medical help during their quarantine, their acute illness periods?
Thank you, Dhuminder, for that question. I think we all agree that these patients should be properly advised because they don't actually know what is going on in their bodies. And before I go into that, may I kindly show the general practitioners some chest x-rays of patients that we came across, right? So now, because the chest x-ray is now freely available in most of the country areas, and especially as a general practitioner, I think we should not hesitate to take a chest x-ray, especially in patients who are that I mentioned as high risk. Okay, even if the symptoms are suggestive of a certain patient, if the symptoms are suggestive, I think even if the saturation is normal, I think it is always important, if you can convince the patient to get an x-ray, to get the X-ray and come back to you to have a look at the X-ray. So this is one of the X-rays of a very obese patient whom we had recently, and I think you can see that he's already on oxygen as well. And you can see that there are bilateral diffuse interstitial shadows in this patient with ground glass opacity. One of the important aspects of these patients are that they will have these diffuse opacities. Sometimes they are in the periphery of the lung, and sometimes they can be diffuse as such. The reticular opacities and ground glass opacities are there. So if you see this obvious X-ray sign in a patient, so they might be compensating with a saturation of 95. They might not be dyspneic. They might not sometimes be ill. So especially in a patient whom you come to with a high-risk patient, elderly gentleman or a lady, diabetic uncontrolled, and you think that this patient is possibly having COVID pneumonia, always, I think, as a general practitioner, try to get a chest X-ray if you can. And if you can't, they send this patient to the ETU so that the patient will be able to assess. So X-ray is a very important thing, and I think it's better if we can remember these X-rays, right? So sometimes these changes can be very subtle. Now, this is another patient whom we had late July, who had this early mild interstitial changes in the chest X-ray, right? We can see these changes, and there's a little bit of air trapping. This patient had COPD as well, and came with a cough, and this patient's PCR was positive. So you might have subtle changes in these patients. And this is another patient, so sometimes you might think that these X-rays are normal, but we can see these interstitial shadows bilaterally, mainly in the bases in these patients as well. So I think, Duminda, I think as chest physicians, as respiratory physicians, I think we have to stimulate our general practitioners, because a chest X-ray costs about almost around 1,100 rupees, and it is not that expensive. Most of the people will like to get an X-ray so that they can be reassured. So especially in this high-risk group, if we are thinking about COVID, I think it is always important to think about getting an X-ray even at the general practitioner level. And if you have any suspicion, refer this patient to a hospital. And then sometimes you might come out something like this, right? So we have seen, I think Duminda will also agree, we have seen pneumothorax coming associated with COVID pneumonia. So in a patient with chest pain coming with shortness of breath, now this is actually the chest X-ray. This patient doesn't have dextrocardia. You will see that the right side is this. He has a right-sided pneumothorax. So sometimes you might see patients with life-threatening conditions. And so this is a very important thing that we have to think about before embarking on further investigations in these patients. So especially in high-risk patients or patients whom you think that patient is coming with shortness of breath, if possible, I think it is always important to get a chest X-ray and see whether there are any significant abnormalities, and then later we can refer this patient to appropriate treatment, right? So now about the concerning factors, I think we have to advise our patients because some of these patients are at home and they will like to stay at home. So one of the most important thing is that, as I think, is the shortness of breath. So they might feel breathless, and if you feel breathless, gradually increasing breathlessness, I think it's very important that you advise the patient to get the patient admitted as early as possible. Now, one of the conundrums that we see in COVID pneumonia is that they are happy hypoxics. So sometimes we know that as doctors, and I think we can remember from our past as well, when you become hypoxic, when a healthy patient becomes hypoxic, even when they reach in the saturation of about 92, 91 due to pneumonia or any other disease, they become severely dyspneic, short of breath, and they are distressed in most of the time. But I think you will agree that when we see these patients with a saturation of 88, 85, they don't show that distress. They might be, we call it the happy hypoxemia patients. So in that, when they're at home also, they might not complain the shortness of breath, that they are ill, and they might think that they are better, they don't have any problem. But what happens is that these patients, when they walk to the toilet, when they exert themselves, like simply walking to the toilet, their saturation will markedly drop. And usually when they are severely hypoxic, it will take more time to bring back the oxygen up to the normal level. So these hypoxic episodes might trigger ventricular arrhythmias and sometimes severe brain anoxia, even for a small time, and the patients can collapse and sometimes die. And that is one of the reasons that you can find many home deaths because of COVID. So because this hypoxia, the patients might not feel the shortness of breath, or else the relatives will bring the patient without any delay. Sometimes they might just feel a little bit of a dizziness, right? They might feel when they walk, they feel a little bit dizzy, and they might neglect it. And so especially if a patient who has been diagnosed as COVID sent home, being young, old, we don't matter. But if the patient develops a little bit of dizziness, mild degree of shortness of breath, I think we have to advise to come to the hospital as early as possible. Sometimes you might be amazed to see their saturation level, sometimes in the 70s as well. They come to the ETO, we have seen many patients. So this hypoxia is very important to identify. So breathlessness might not be one of the main presenting complaints. Unfortunately, even though we tell them, they might have a mild cough, a dizziness, not feeling well. And especially if you feel that, ask them to come to the hospital as early as possible. That is the first thing, especially in this age, in these groups of high risk patients. Especially, I think, especially if the patient is having pregnancy, uncontrolled diabetes, chronic renal disease, and these type of patients that we describe, morbid obesity, I think always it is better to be careful about this patient and err towards asking them to come into a hospital rather than asking them to be staying at home, so that we can actually investigate, take a chest x-ray, check the saturations, and appropriately manage them and observe them in a hospital setup rather than at a home setup. Because unfortunately, when they come to us in an ambulance 1990, it might be a little bit too late, and there were many patients who died within about, after admission, within about 1 or 2 hours, even after admitting, and some of them had died at home, and sometimes even 5 to 6 deaths occur at home without any cause. So I think we have, as general practitioners, I think we have to always stress that these patients, identifying the at-risk patients and advising them in an appropriate way would be the most important thing. And if the patient can afford, a pulse oximeter, a finger pulse oximeter should be prescribed to these patients so that they can monitor their saturation at home, especially after walking a few minutes or sitting and standing for about 15 to 20 times, so that they can monitor their saturation. And if there is a even in a mild drop, about 2% drop after getting exertion, I think we have to get the patients in as early as possible into hospitals.
Yes, Neranjan, I think that was a very, very important factor that you mentioned about the happy hypoxia, because our patients also have there's a feeling that if you do some exercises, you get better earlier. You get better sooner if you don't rest. So that is not the case with COVID, because you need a good rest during the acute phase. So that's very important for the GPs to inform their patients that you need to rest. And apart from what Neranjan mentioned, also persistent cough can, in fact, that X-ray he showed last, the pneumothorax. The persistent cough might cause what's called self-inflicted lung injury in most of the patients, and which can develop into a pneumothorax. So I would say if a patient is having persistent cough, that might be another indication that the patient should seek some medical help. And also we have seen some patients with diarrheal illness and vomiting and GI symptoms, a lot of GI symptoms, who also does poorly and who might also need resuscitations and other intense monitoring. Then I would also think about this thrombosis. Do you agree, Neranjan, that thrombosis
Yes.
also, if the patient has significant headache or any evidence of leg swelling, that might be another indication that they would come out to GPs and or to the hospitals. So yes, so I think these are the most important features that you should mention to your patient, that they should be monitoring when they are staying at home during the acute phase. So already now Neranjan mentioned some of the very important conditions. Those are some local experience: the diabetes, chronic kidney disease, other renal problems, obesity. And if you look at the international literature, actually, their risk factors are slightly different. If you would agree with me, Neranjan, they have ischemic heart disease as the number one priority. Yeah. But in most of our patients with heart diseases, they did not do that poorly. And we have seen even MI patients, they get quite well, and we were able to discharge them. Yeah. So our local experience, I think that's again very important. So if you go to the next segment, about the treatment. So for these patients who are at home, or maybe who are getting admitted, or to these high-risk patients, what are the treatment options available, and what can our doctors can advise their patients?
Yeah, that's a very contentious issue, isn't it? Right. So we had to be very careful there. We had to be very careful on talking about that issue, because there are a lot of things that are there currently being prescribed to various patients. And finally, I think we might have our own opinions regarding various things. But I think what the main important thing is, if there is one way out of this pandemic, it is by following the science. If it is by science, not by anecdotal evidence, not by thinking about various miracles. No, I think it is by science. So we have to stick to science, basically. So the current evidence base of science, the best practice evidence is the randomized control studies, and it will give us the best evidence for certain interventions, especially now the general practitioners view. It is the early interventions that we have to talk about, not the hospital admissions. So for example, at the hospital, dexamethasone has been proven to be saving life. Remdesivir has been shown to be saving lives. Tocilizumab, tofacitinib. So those are the drugs that we usually give when the patient is admitted and needs oxygen and hypoxic and further management. But at the early stage, that is the contentious issue, because now in COVID, unlike in most of the viral infections, most of them are asymptomatic. So if we have 100 patients and if we give something like a tablet of wheat flour, anyway 90% of them might not have any problems, right? And 5% will have severe disease, right? So sometimes people might interpret that majority are better because of this wheat flour tablet. So for example, so hence I think it is always important as doctors, because when we are thinking about prescription, one of the major factors that we have to consider is, when we are about the medical profession, we have 4 pillars of ethics. One thing is maleficence, do no harm. Second is do good. Third thing is justice, and then autonomy. So those are the things that we have to think about. Always look at the perspective of the patient, autonomy, but always as a medical practitioner, as a scientific person, we have to go according to the evidence that is currently available and it is practiced. So hence, at the moment, for the early COVID, I think none of the treatment have been recommended by majority of the CDC, the WHO, and various organizations. They have not recommended certain tablets or certain interventions. But we should agree that there are some interesting and important things that are coming in. For example, ivermectin is there, but again, the current recommendation of the CDC, current recommendation of the CDC says is that the evidence base of ivermectin, that is the power of the recommendations, are poor because these studies have not been properly done in a randomized way. And there are studies about the budesonide inhaler as well. They have shown benefits, agreed, but still it is yet to come into the guidelines and the practice. So we as medical practitioners, we should not prescribe unnecessary treatment thinking that it will be successful. I think that is my personal opinion, unless we have evidence to suggest that. For example, now azithromycin is said to be, they have been proved that it is not useful. Hydrochloroquine has been proven that it is not very useful. Those are the drugs that they have been proved. But unfortunately, one of the things that I should highlight is that to conduct a proper randomized control study in people, it involves a lot of expense, and hence especially the generic drugs like dexamethasone, hydrochloroquine, ivermectin, they are generic drugs. Hence the companies will not fund these randomized control studies. If they have built up a new clinical entity, for example like remdesivir, they will definitely fund it because they will be able to get some outcome from financial benefit from this. But those drugs that already have been generic, they will not fund these randomized control studies. So probably what we need is, at least in the Sri Lankan context, that is a country level, if there are studies that shows that a certain intervention is beneficial and not that harmful, for example, like ivermectin, we should be able to conduct our own randomized controlled studies and our studies to see whether this for our population, whether it works. And if it is works, I don't think we should go behind the WHO or the CDC. We should if the properly randomized strong studies have been done in Sri Lanka. We have a lot of intellectuals. We have so many professors in the medical faculties of medicine. We have so many people in the community medical departments who are well equipped with international experience to conduct these trials. So I think it is time, as as a community, so that we can conduct these trials for substances that actually had been proven or had been shown to be of benefit. But until we have clinical evidence to say that it is beneficial, I think as medical practitioners, we can't recommend certain treatment options, especially in the early stages of COVID. And certainly, I think we should not recommend certain other practices. Like I will show you one important thing, this one. All right, so this is actually I got from the Facebook. I have obviously cut this off because I didn't want to promote this, right? So itamat durlabha, and there is some substance that is there. It's a leaf, and then 100 ප්‍රත්‍යක්ෂ විසඳුම, right? ඕනම සෙම්මාශ්‍රිත රෝගයක් දින තුනේ සුවයි හිමාලය අල්ලන්න දිනපතා පානි කරන්න. And I will tell you a personal experience. Mine, one of my very close relatives, right? Relatives have been, he's also a medical officer, right? Unfortunately, young person has drank this substance, right, for 3 days on a row, like candle, and then he developed severe diarrhea. His creatinine went up from 80 to 200, acute renal impairment, and he was severely he has diarrhea, and he was almost unconscious. And fortunately, after hydrating, they were able to get him back to the normal. So sometimes even doctors, even who are treating, who are very, very skeptical about this treatment, unfortunately, they go and do this type of thing. And especially about Himalaya, I think we should not ask the patients to get to steam, right? Because some people think that it will destroy the virus, and it has not been proven. And especially when to actually destroy the virus, you should have at least about 70 to 80 centigrade, which you can't tolerate, right? So normal Himalaya is not recommended, and there might be other problems. And some people, what they do is they put various leaves to these substances and then try to inhale, and that is one of the cause of pneumonitis. Recently, we had a patient with pneumonitis because of they have inhaled certain substances in the Himalaya. So I think we are not different from these people. If we go on prescribing unsolicited, unrecommended drugs to our patients, even though we are giving it in good faith. So the important thing is seek the scientific evidence, and if it is scientifically there, yes, we can do that. But else, I think it is always we have to be very skeptical when we are prescribing to our patients. So that is the message that we have to give, isn't it, Duminder?
Absolutely, yes, Neranjan, because most of our asthmatics, they are dead scared that they would contract the virus.
Yes.
And they might be one of the groups that go behind these treatment options. And it's not uncommon for these asthmatics to go for certain inhaled therapies like what you mentioned. And of course, they go into further trouble. They develop bronchospasms. They can have inhalational pneumonitis. I have seen patients with what you call this cajulity.
Yes,
they have inhaled this smoke from cajulity, thinking that it's beneficial for them, and going to severe trouble. So it's not uncommon. So we have all these, we have the cases, and also I think mothers have done steam inhalation to children, and we heard from our pediatric colleagues that there have been thermal burns of the upper airway in children. So all these things can happen. So it's not scientifically proven, as Neranjan just nicely explained. So yes, so you have to go by the science. So at the same time, there's a question about aspirin. If I quickly take that question, how about prescribing aspirin if suspected thrombosis? So my what I have read is that if you are on aspirin for any disease, yes, you should continue your aspirin. But early COVID is not an indication for aspirin. But of course, if you need admission, if you are in stage 2A, that is, if you are in the late pulmonary phase where you get X-ray changes and you need oxygen therapy, then you need thromboprophylaxis. So you need enoxaparin as a treatment option, as an inward treatment option. So anything to add on that, Neranjan, about
Yeah,
aspirin?
Dhaminda, now that is the thing now, isn't it? Now, especially now when you look at the mechanism of action, especially because COVID is a thrombogenic disease, some people might think that prescribing aspirin might be benefited, and actually they have done studies, but at the moment they have not proven to be of significant benefit. The only thing that, as you said, is that patient who is already taking aspirin, clopidogrel, or any other anticoagulant, they have to continue it. That's no question about it. But giving it as a prophylactic agent is, at the moment, it is. I think it is not recommended, as you correctly said. Yes.
Yeah, and also there are a couple of questions about zinc and also vitamin C supplementation.
Yes.
So this has been very commonly practiced, isn't it? So
Yes.
of course, vitamin C. There are some patients who had gone into metabolic acidosis following excessive ingestion of vitamin C. We know it's ascorbic acid, especially in patients with renal impairments and all. Anything about that, Neranjan, zinc and
Yeah, I think
vitamin C?
again, when you look at zinc has been shown to be having antiviral properties, especially in vitro studies, as well as it is actually, as we already know, it is a important substance in enzymatic activity, and it has shown to be enhancing the immunity as well. But at the same time, it has also not been proven to be of significant benefit in most of the instances. So, some people actually give packets to these patients, isn't it? Because now, if in certain countries, I will not name the country, so they have given certain drugs like doxycycline, zinc, and ivermectin, and some other vitamin C tablets to these patients in a whole mass scale. But as I told you, Dhaminda, sometimes we have to be a little bit careful about what we give to the patient. So unless it is scientifically proven, I think we should be very careful in prescribing this patient. That is the thing that we can say as medical practitioners and as professionals, because we can't recommend unscientific treatment for this patient, because we are also legally liable as well, isn't it? So if someone, someone goes into courts saying
generally,
that, why did you give me these drugs? And we should be able to defend ourselves. At least we have to be able to get it in the guidelines, and that is why I gave it to this patient.
Right. Generally harmless drugs, but then again, there can be occasional individual who might not be the ideal candidate for some of these drugs. So you have to be careful if you are prescribing. Generally, zinc and vitamin C, not that harmful, but yes,
not that harmful.
There can be. There can be.
And there's another question, Dumit, about vitamin D as well. Again, vitamin D has, especially as you know, has shown to be very beneficial in patients with chronic lung disease, especially tuberculosis, COPD, and in Sri Lankan context, even though we are a very temperate country, sometimes, especially people sometimes tend to be inside, the people who are doing office-based work, they are deficient. They are sometimes deficient in vitamin D. So it is a case-based assessment. So if you think that this patient has a possibility of being vitamin D deficient, I think there is certainly a place for vitamin D prescription in a short duration of time, if you're thinking about that. But else, also, I will not recommend it as a whole. But I have to tell you that sometimes I prescribe vitamin D to certain patients, especially if they have chronic lung disease, and if this patient is usually in the home environment, because they are not exposed to the sun a little bit, sometimes they might have a bit of a vitamin D deficiency. And vitamin D also, we have to understand that vitamin D, if overprescribe it, we can have vitamin D toxicity, because it is not usually taken out. It's a fat soluble vitamin, so not overprescribe for the short duration of time. Sometimes in appropriate patient we can prescribe vitamin D, but again we have to go according to we should be able to defend our prescriptions.
Absolutely, yes. So before going to the next segment, there's a hand raised, Mr. Hussein. Do you have a question there, or is it by accident, Mr. Hussein? Do you have any? Do you have a question there? Your hand is raised. Right. Okay. So I think now we are coming to another important segment in the discussion. So it's about the post-COVID. Yes, Mr. Hussein. Yeah.
Sorry, I'm Dr. Marjan here. I want to
yes.
I want to know now
Yes,
small
Dr.
children
Marjan.
are coming with fever and diarrhea and vomiting.
Right.
And it looks like, you know, it's a we are suspecting maybe a COVID. So I want to know if in that context, how can we diagnose, or even throat swab or nasal swab, will it diagnose COVID, or PCR will be positive?
I would say yes, because the portal of entry for the virus is usually the upper respiratory tract. They can have multisystem manifestations, but usually the portal of entry is the respiratory tract, and the virus is present in the nasopharyngeal swab. In certain countries, they take GI samples also for diagnosis, but we do not do, as far as I am aware. Do you have anything to add to that, Neranjan?
Shall I interfere? My silly idea. Don't misunderstand me. Can't we do ret on the diarrheal stool sample?
Dr. Hussein, I think that's an interesting suggestion. The important thing is now, as you know correctly, so in the early stages, when we had this concern whether dead bodies can cause a pandemic in patients after water contamination, they have done a study in Netherlands where they have in the Schiphol airport, they have done samples from the sewage and they have found PCR positivity in COVID PCR positivity. So now that is a good thought in a patient who has suspecting of COVID. I think yes, to see whether this patient is having COVID. If we identify even a small viral particle, I think that indicates that this patient is having COVID. So as a diagnostic test, we can use various samples from the patient. So that is a very good thought. But as Duminda said, I think and then you have highlighted a very important patient, especially with children. I'm not a pediatrician. I hope Professor Kudagaman and Dr. Vasana Kiridana might be able to add for that. So, but children can have, as I told you, atypical presentations with abdominal pain and diarrhea as well. So in the appropriate clinical setting, I think we have to suspect COVID and we have to investigate them with using the appropriate clinical specimens. But as far as I know, I have not seen a recommendation about using PCR from the stools in Sri Lanka.
Professor Kudagaman and Dr. Kiridan, do you have to add anything to that?
Before that.
Yeah, in a child presenting with GI symptoms, it could be parenteral diarrhea rather than an infective diarrhea. So I think nasopharyngeal sample is the specimen we need to do PCR on rather than a GI sample.
Right. Okay, thank you. And thank you, Dr. Marjan, for that question.
There are some very interesting questions. I think we should answer them at the end, isn't it?
Right. Yeah. So we will go with the discussion. There's only about 1 or 2 segments we have we have left. So we are coming to a very important, again, very interesting section now on the post-COVID. There's been a lot of talk now about post-COVID, and now there have been millions of patients who have been discharged following COVID. So now the post-COVID is the highlight these days. And in fact, there are a lot of post-COVID clinics that most of our doctors are conducting in almost all hospitals. And I think Neranjan is also conducting a very active post-COVID clinic at Rathnapura. So after discharge or after the initial, once after recovery, so we say generally after about second week, if they are asymptomatic, they are recovered, or if they are even having mild to moderate pneumonia, after the third week, they might be considered recovered. So what can the GP, now I'm sure that a lot of patients come to their GPs for a checkup. So what are the things you should look at, and what are the advices you should give your patient? And also there are a lot of campaigns going on. very interesting campaigns. There are whole body examinations, very expensive campaigns. So do you recommend these things? Any ideas, Neranjan?
Unfortunately, isn't it, Duminder? And I think you'll all will agree. And for some, COVID has become a huge business, right? It has become a business, and they will do anything to earn a little bit of money, be it the hotel sector, be it the antigen sector, certain drugs, certain other quack medicines. And now they have used, trying to use the post-COVID scenario to gain a buck, unfortunately. But I think as scientific people, we have to be very vigilant about those aspects as well. And thank you for highlighting our COVID clinic. This is our COVID clinic, which is held at Teaching Hospital Rathnapura every Friday from 8 AM at room 57. And basically what we are doing here is that any patient who has been discharged from Teaching Hospital Rathnapura, who has been an inward patient, as well as a person who is referred by a consultant, or a person who is referred from outside hospital, who is, for example, a patient from Rathnapura, if he's in Peradeniya, the patient can be referred. They are inward patients. So currently we are actually seeing the inward patients and the consultant referrals, because we have a huge load of patients and we have to identify the patients who need priority. So last Friday's clinic, we had about almost 60 new patients. And when we had lunch, my team had lunch, it was about 4:30 or 5 PM in the evening, after starting the clinic at 8. So we had to investigate these patients, and I have to thank my team, my medical officers, you can see here. And I will not name them by name, but I'm very thankful that this is actually Hasranga Joy, and we have a lot of medical officers involved. So post-COVID clinics we conduct in hospitals to certain groups of people. But so what is post-COVID is the most important thing. Now, this virus is a very interesting virus. It doesn't go off. Now, for example, we might think that you get post-COVID symptoms only in patients who are severe disease, but various studies have shown that whether you had asymptomatic disease, mild symptomatic disease, moderate or severe disease, your probability of having post-COVID syndrome is much higher. So there is no association between the severity of the disease as well as the symptoms that you had. So what is basically post-COVID? That is symptoms that cannot be explained by the viremia or the immune reaction of a person that exists more than for 28 days usually. So these patients can be lumped into certain groups, mainly the respiratory symptoms, where these patients will come with shortness of breath, chest tightness, and patients will have basically some persisting cough. Those are the things that the respiratory problems that they have. They might have a little bit of pricking type of chest pain. Sometimes they can have severe chest pain and might mimic cardiac problems as well. They definitely will have musculoskeletal pains, joint pains, arthritis. That is another group that these patients can come. And they can also come to us with neurocognitive functions. They can come with abnormal types of headache. They say like a burning type of a headache. They might come with features suggestive of migraine. They might have sometimes especially patients who are executive groups, they will not be able to take executive decisions in a rapid way. So I had a manager who came, a tea factory manager who came and said that after he went into the tea factory, he can't make decisions. So that is basically what we call cognitive fogging. So executive decisions, especially in a person who is in a bank, when you're counting money, you might make a little bit of a fuss there. So you might be a little bit anxious, you might be a little bit depressed, right? So neurocognitive functions and neural problems, the respiratory problems, the cardiovascular issues, and the musculoskeletal issues. There are a lot of issues that can come as post-COVID syndrome. And one such issue is the chronic fatigue syndrome, where it has been associated with post-COVID syndrome. So they are markedly fatigued. After about doing 1 or 2 hours of normal day function, like washing the clothes, they will feel significantly fatigued. And especially we have a lot of staff patients who are coming after having COVID, and they say that when they are doing duties, when they are climbing one stairs of steps, they feel a little bit more breathless. They can't do their daily duties. They are more emotional about it. So it's a huge problem that we have, and majority of these COVID patients will come to our general practitioners. And first thing is that it can mimic many things as well. It can mimic, sometimes we might think that this person is malingering, and they might think about psychological issues. Sometimes we might think about conditions like migraine, and sometimes we might think about conditions like asthma and wheezing, ischemic heart disease, rheumatoid arthritis. So we might think about various diseases. And another thing is, sometimes these patients, COVID patients, are prone to get these conditions as well. For example, a person with headache, severe headache, the actual cause might be a central venous thrombosis. That might be the cause. A person who is having shortness of breath with a chest tightness might have an myocarditis, which was not detected while the patient was there. And a patient who is having wheezing might have an acute exacerbation of asthma, or a post-COVID pneumothorax with shortness of breath. And so there are a lot of things that we have to think about in these patients. So post-COVID is a very, very complicated issue, and we have to manage these patients appropriately. And one of the major aspects is the counseling that we have to tell the patient. Some of these patients, especially we have patients who are working in the banking sector, when they had COVID, they were taken into a hotel, and they were actually quarantined and given the facilities, and they were okay during the 14 days of quarantine. They were better without no significant issue. But the next day they come into work, they feel fatigued, they feel overwhelmed, and they can't work as previously. And some people might think that they were okay when they are quarantined, but now they are complaining because now they had to work. But no, they have a certain issue, because they are in the quarantine center. They didn't have to go through the daily chores. They do, especially the females, our mothers, they didn't have to cook. They didn't have to do the daily chores. But when they come home, they have to do the whole thing again from the beginning. And people might expect to do as she did previously, unfortunately. But certainly she will not be able to live up to the standard like previously, because the severe fatiguability that the patient has, and she will become anxious, and later might be becoming depressed as well. So the important thing as doctors is to understand that there is such a phenomenon as post-COVID syndrome, and some of these might be due to genuinely abnormalities in a morphological sense. So they might have abnormalities in the chest, changes in the heart, liver dysfunction. Those are the things that we have to think about. They can have. So it's as doctors, I think we have to exclude those before thinking about non-organic factors causing post-COVID syndrome. So after excluding these possibilities, always I think we have to counsel these patients appropriately about taking it easy. Right. So what I usually do is I advise them that you will not be normal the next week or the next week. You will be normal in about 3 months' time. It will take about 6 to 12 weeks to bring yourself back to the normal state. And don't worry about it. Take things easy. Don't try to go into the treadmill and do the exercises that you did before you had COVID. Take it easy. First, let you recover about 2 weeks' time. Start slowly, 5 to 10 minutes. Gradually increase your daily workup, and then gradually increase your daily chores, and gradually increase your executive function, especially if you are dealing with a significant amount of management and executive functions as well. So I think, Dhuminder, yes, as you said, most of our hospitals, we have started post-COVID clinics, and we have to thank all the staff categories, our medical officers, nursing officers, as well as our junior staff, as well as the administrative, for supporting with this. And because of that, we are able to conduct these clinics in a nice way. And because of that, we are actually able to manage most of these patients in an appropriate way. But when the patient comes to the general practitioner in the outpatient setting, I think we have to understand the complications properly. So one major important thing is to exclude organic pathology. That is the most important thing. If a previous X-ray is not taken, take a chest X-ray, and you will see, if you see lung opacities, yes, now this patient has an undiagnosed organized pneumonia, refer this patient appropriately. If this patient had take an ECG, see whether there's evidence of cardiac dysfunction or myocarditis, refer this patient appropriately. Liver dysfunction is one of the major causes that we have seen post-COVID. Liver functions getting elevated up to 300, 400, sometimes 900, which might not be detected previously. So if you think there is a problem with loss of appetite, vomiting after we having COVID, we have to think about those dysfunctions as well. And then if we think about the organic aspects, the important organic aspects, and if we have excluded them, then we have to address these patients in a psychological way and ask them how to manage their day-to-day functions and advise them about nutrition, reduce the carbohydrates, increase the vitamins and the nutritious substances, fruits and vegetables. That's the most important thing. Avoid drinking milk and other cereals and things like that. And, have increasing amount of protein substances like fish and egg white. So I think that is the way that we have to advise. I address the organic dysfunction, identify them. Second thing, address the concerns of the patient. They are always very afraid, and sometimes without any symptoms, they come with anxiety, knowing they just want to know whether they are normal or not. Sometimes they come like that. So you can reassure after doing appropriate investigations that they are normal. And the third thing is advice about the nutrition, proper nutrition, and ask them to avoid unnecessary candles and unnecessary kasayas, unnecessary substances, so that they will develop other problems. And the other important thing is address, especially in patients who are working, about their work environment, right? So ask them to take it easy, don't take hasty decisions, and gradually come back to your normal states. For example, I had a gem businessman coming to the clinic. What I told him was, don't make significant business decisions about selling gems during the next few days, because I advise them like that. So, so we have to make them aware about these problems, and we have to tell them that it is not only you that these patient the problems have. It is a normal common thing. I usually talk with the spouse in front of the person as well, because then they will know that he's not mimicking or she's not mimicking problems just to stay away from work. So that is the general aspect that we have to address. So it is not a simple issue, the post-COVID syndrome, and we will have many, sometimes even 100,000s of people who are coming with post-COVID syndrome during the next 1 or 2 years. And because now COVID is here to stay, we will have this problem even in vaccinated people, right? Even in vaccinated people, they have found that post-COVID syndrome, not because of the vaccine, we know vaccinate patient having COVID and then recovering completely, even without any significant problem, they also have a tendency to develop post-COVID syndromes. So there's a huge group of people who will be coming to us, to the general practitioners, during the next few years with various issues, and we have to address that, and we have to have a mechanism to address them. Thank you, Dhuminder.
Yeah, absolutely. Yes. Thank you, Neranjan, for that very elaborative presentation on the post-COVID. Yes, that's very important. And our clinics are getting heavier and heavier, and we need a more sustainable mechanism. That's definitely, yes, it's the truth. And also, there were a lot of interesting things in that discussion. So, if I may highlight again it's very important the patients take it easy. So they do not rush for their exercises. So there are some people who are very energetic, and they want to go back to their routine to do all the exercises, to go to the gym and everything. So they come and ask whether, doctor, can we go to the exercise? Now it's about 1 month after. So again, if I go to the timelines now, the NHS, the European guidelines, they say the acute COVID can stay for 2 to 4 weeks, and from 4 weeks up to 12 weeks, that is the early post-COVID period. Then after 12 weeks, you call it long COVID. So sometimes some people can go into long COVID. So the people who are at risk for going into long COVID are usually people who had pneumonia during the acute phase, and also the elderly and other patients with comorbidities. So there are a few categories that when you're talking about the post-COVID. Now, Neranjan nicely explained about the asymptomatic people who are at home, and then later on who developed these complications. After about 2 weeks, 3 weeks, they get bronchospasms, they get this fatigue, they get this cognitive fogging. So it's very important symptoms. And also, I'm sure that Vasan and Tushar might be able to tell us about these MIS-C in children, that is multisystemic inflammation, that also may occur after about 2 to 6 weeks, within that period. So not in the acute phase. And also, I think it's very important now the government, the national guidelines, sometimes, because the guidelines it's not only you have look at many parameters and also the resources available when you make the guidelines. So the discharge criteria is now changing. So now, of course, now we discharge people usually on day 10 from the hospitals. And right now I am treating a patient who was discharged on day 10, and then around day 18, patient has presented with the pneumonia. To see that is a post like a lung involvement, COVID lung involvement with a secondary bacterial pneumonia. So patient is still having the complications of the acute infection, which has not been detected, and that patient we might not even be like, we might not recover that patient. That patient might succumb to her illness.
Yes.
That's an elderly lady who's having some complications. So this is a patient who was discharged from the hospital. So that is not unheard of. So these patients again might come to you for GPs. So you have to think about now, make sure you calculate the day. What is the illness of the day? Is it third week or fourth week? So third week, you can get still bacterial and fungal pneumonias if the patient was treated with steroids, especially. Fourth weeks, you can have these DVT problems, pneumothorax, late pneumothorax, and then there are these complications. And also, interestingly, Neranjan, I had a patient who had a pneumonia, COVID pneumonia, but he was discharged around. He had like a slightly prolonged hospital stay for day, I think around day 16, day 17, was discharged. Patient is quite stable. He had a 2 weeks leave, and then he's a forest ranger who he went to Novovex for his job to work. And when reaching Novovex, he carried his pulse oximeter. He's usually having it 97, 98 at home, and it dropped to 91, and he was feeling dizziness. And he immediately descended, and only once he came to Ramboda area, and he got back to his normal routine. So that is, we have not heard of that before. So we are also learning. So there are a lot of new things that might be coming up. So there are many things to be on the lookout. So that's about the post-COVID complications. And also this resting tachycardia, I wanted to highlight, Ranjan, again.
Yes.
The patients who come to our clinics, some people are having pulse rate of around 125, 130. They're
Yes.
asymptomatic.
Yes.
So if a patient asks you whether he or she can exercise, please check the pulse if it is within the first few weeks after discharge, or like within the first like per month, 1 or 2 months. And if the patient is having tachycardia, that might be asymptomatic myocarditis. Initially, we have actually done the troponin, which has been, of course, normal. But then we don't know, with exertions and no exertion, these patients can go into complications. So make sure the patients are back to their normal parameters before you advise them on exercise and other heavy strenuous activities. Right. With that, Neranjan, we have to discuss about the vaccine, but I saw there were a few questions in the interest of time. I think shall we go to the questions? Is that all right? Or are there is there anything you want to
we will finish about the vaccine. Yeah, I think it's better to finish about the vaccines, and then I think it's almost finished after that. So
okay,
discuss about that.
Yes, Neranjan, you can. You can talk about the vaccines.
I think, isn't it, Dominda? Now, vaccines, it has been a very hot topic due to the wrong reasons, unfortunately, right? Because various people have various things about the vaccines, and some people think that this vaccine is better than that is better than that. Because it is made in USA, it's better. It is made in China, it is sometimes problematic. So, but anyway, about vaccine, I think we have to as medical professionals, we have to be firm. We have to be firm and come into a single conclusion, right? So this is the spectrum of disease of COVID. Okay, so we have basically in the right side, we don't have any significant infection. That might change actually later. Most of us now, I think now it is just when you will get infected, or it is not whether you will get infected, it is when you will get infected. Because I think that all of us will be infected because of COVID due to one time or another, one day or another. Okay, right. So, but anyway, there is a people who are not infected. And there are the fortunate who don't have any symptoms. They are better. They don't have significant symptoms. And in this spectrum, they might develop a little bit of nasal congestion, cough, a little bit of wheezing, and then they come back to normal, and they develop the moderate symptoms. As Dominda said, there will be shortness of breath with significant breathlessness, and then the severe symptoms with hypoxia, and then they will need hospitalization and death. So the most important thing is to reduce any intervention, to reduce deaths. That is the first and important thing. Reduce the hospitalizations, because the health sector cannot cope up with the significant amount of hospitalizations. And the second thing is, we are filling the patients with COVID, and the non-COVID patients will not get the treatment. Myocardial infarctions will not get the treatment. The hospital and the healthcare resources will be utilized completely for COVID. And because of that, even though the patient will be sent home, there will be another person dying because of non-COVID disease. So we have to reduce hospitalization of the COVID patients because of that. And at the same time, usually the outcome of the hospitalization of the patient, they might have significant comorbidities, morbidities even after getting discharged. Patients with severe symptoms, again, they will have significant lung deformities. They will have, as Duminder said, myocarditis. They might go into renal impairments, and they might have multiple issues as well. So in any intervention, the most important thing is to prevent severe and moderate hospitalization patients as well as death. So what are we talking about efficacy? Now, when we look at this graph, right, we have the various vaccines that are currently there. So we have the Pfizer and BioNTech, which is basically an mRNA vaccine covered by a beautiful nanotechnology lipid particle. And then we have the Moderna, right? And then we'll have the Johnson & Johnson, all three from USA. Now, these two are the mRNA vaccines, basically developed in the same way. They have differences in what you call this, how we keep the vaccine, but they are basically mRNA vaccines. A part of the mRNA, which codes for the spike protein, is enclosed in a particle and then injected to our body. Hence, the mRNA will travel to our nucleus, and then it will transcribe the viral spike protein, which will be put out and then identified by the immune cells and produce antibodies against the spike protein, which is the most important thing. That is the usual mechanism of the Pfizer and the Moderna. Basically, then we have the Novovex vaccine, is a new vaccine where you produce the protein outside, especially the MOT cell, where you stimulate by using a viral vector. Again, you introduce it to the active cell, and from that you produce the spike protein, and this spike protein is taken out and purified and given to patients. Then we have basically the adenovirus vectors, where you get the adenovirus, and this adenovirus, we remove the DNA from that virus. We insert the content from the COVID virus, where the mRNA can be developed and then insert into the virus and then be injected. And usually now AstraZeneca, we have the chimpanzee adenovirus, and then in certain other vaccines like Sputnik, we use the normal adenovirus. The reason is that adenovirus is a very common virus, and sometimes you might have immunity against it already. Hence, that is the reason that the Oxford group has chosen the chimpanzee vaccine. And then we have the vaccine where it's killed vaccine, like the Sinopharm vaccine, where you have the removal of the genetic particle and you give the protein capsid only, where it's a killed vaccine. We are not using the live attenuated vaccine at the moment. So it is basically an mRNA-based vaccine. We are using the vector, we use it as a nanoparticle or adenovirus, and sometimes we use the protein vaccine, the subunit vaccine like Novovex, and sometimes we use the killed vaccine like the Sinovac. So if you look at the efficacy that has been given in this group about having the disease, you have range from 95 to 60. But the importance, it is not what is important actually. And to tell you the truth now, when you looked at these studies, some of these studies have been done when the alpha variant was there, right? And some of these studies have been done with the delta variant of there. So these efficacy levels of viruses, of preventing you getting from the disease, might actually not represent the true potential of the virus. Hence, the most important thing, as I told you, that even now the people who have given for 2 doses of Pfizer, especially in certain countries, have been infected now with the COVID virus because of the variants. So rather than going into the efficacy when you're considering about the infective preventing issue, the most important thing is to see whether this virus prevents serious illness, death, and hospital admission. And you can see that most of these vaccines, almost all of these vaccines, can have a more than 90% efficacy in preventing deaths and hospitalizations and severe disease at present, even against certain variants that have been developed at the moment. So as medical professionals, what I think we should tell the patients are that whatever the vaccine that you have, get the 2 doses. That is the most important message that we have to give our patients. I think about the vaccines, I think there are various concerns. Some people try to get the the various vaccine types going into certain areas, so there are certain age concerns about certain vaccines, because some of them have not been studied in certain age groups, and I don't want to go into that, because at the moment our pediatricians are going into the details about certain vaccines, about how to give them, and what are the age groups, and what are the comorbidities that you have to consider. And probably by Friday we might be able to get the recommendations from the Pediatric College of Pediatricians, especially when you are thinking about people who are less than 18. So I don't want to dwell in that. They will, I'm certain that they do a beautiful job, because they are very, very concerned about this patient. And I'm really happy about how the College of Pediatricians is approaching this problem as a complete group. So as physicians, as adult physicians, we can learn from the pediatric college, I think, isn't it, Tuminda? Right? But anyway, I think the most important thing is, whatever the vaccine, I think we have to advise our patient to get the 2 doses as early as possible. I think that is the message that we have to give about vaccine.
Yes, Neranjan. Yeah. So so there's a lot of things to talk about vaccines as well. Shall we then go to the questions? I think there are a lot of interesting questions.
I think there are some very interesting questions,
Yeah.
and because we have now 1.5 hours gone, I think
So
we'll
take another half an hour.
Yeah, we can take within the next 15 minutes, we'll finish it off. Yes.
Right. So to start off, there's a question for Vasana, I suppose. Is there a place to check COVID antibodies in children where they have never been symptomatic and not tested? So basically asymptomatic children of doctors' children, because there's a risk for them to get exposed. Dr. Kirdana, are you whether do you check antibodies? Is it like recommended?
We check antibodies only when they have any post-COVID manifestations, not otherwise.
Yeah. So if you clinically indicated, because the PCR can get negative, no? That in that state, it's like, so you might have to go by antibodies. Again, the antibodies, presence of antibodies just routinely will not say whether the child is protected or not as well, because those are not.
It is said only about 65% would show antibodies.
Yeah. And also those are not neutralizing antibodies as well. So there's a debate whether these antibodies, the presence, whether that have any protective effect also. So yes, so unless indicated, only if indicated, you would do.
Yeah.
When vaccination done after getting the when vaccination should be done after getting infection? Yes, because most of our population, they are usually now of course they are both vaccines. They have got both vaccines, but some time back people have only got one vaccine and they got COVID infection.
Yes.
So when can we recommend the second vaccine? I think what the CDC, when I read last time, what it mentioned was, if you are given monoclonal antibodies or convalescent plasma, then of course you have to wait for 3 months. And also following this MIS-C, multi-inflammatory, multisystemic inflammation syndrome, where you treat them with IVIG or even steroids, high doses. Again, you have to wait for 3 months. Otherwise, the vaccine, it can interfere with the vaccine efficacy. But if you look at our mass vaccine campaign, I'm sure that half of the people who are getting the vaccine right now are having COVID infection.
Yes.
Otherwise, I don't think there's a big problem. So generally, we advise them to stay about 1 month after the date of infection.
Yes.
And then get it. Is that Neranjan?
Yeah, I think that is a rational answer, isn't it, Duminda? Now, usually most of these vaccines have been to be efficacious after about even after you give the first dose, you have to stay about at least 7 to 14 to 28 days, depending on the vaccine type, isn't it?
Right.
So almost having the infection is almost like having a live attenuated vaccine, isn't it? Live vaccine.
Yeah.
So it is rather rational to tell them to stay about 3 weeks or 4 weeks after getting a diagnosis before the next vaccine. But even before that, if they can get it done, I don't think there is no harm, but the immune boost effect might be better depending on the vaccine, depending on the time. So, but rather than having discriminations, I think we have to promote the 2 doses of vaccine as early as possible in an appropriate setting, except in the cases that you have told, which will be very, very rare. MIS-C infection, MIS-C, as well as when we have given convalescent plasma. So I think that is a very important message that we have to tell. So another thing is, I think we have answered this question about the diarrhea. prescribing aspirin, we have answered. Zinc, we have answered. What about drinking coriander? Now, we actually, I think, isn't it, Dominda, we from the, when we were small children, our tamas were very fond of giving us kottamalli, and we were brought up right, isn't it? There was no problem about it. But if you want to drink coriander, what I suggest is that if you like coriander, you can drink, but thinking about it as a cure for COVID, I don't think we have any evidence. But if you like to drink, not the kuda, not the grinded form that you can buy from the market, because we don't know exactly what it is containing. But if you can, get the absolute coriander seed and then have it prepared, I think, or you can prepare the powder in your home, I think you can be absolutely certain that you are drinking coriander, not something someone else's kasai or something like that. Then I think I don't have anything against coriander if you like it, even Venimelgata if you know about it, you are drinking. But that is up to you. But scientifically, we can't advise for or against that. What do you think?
Also, Neranjan, just
Yes.
to mention that, yes, that's true, that we have been taking coriander and all these things for generations.
Yeah.
But in moderation, because our grandparents, they didn't drink coriander like 4 times a day. That's maybe once or twice. So we should not because sometimes even this kasaya packet, they have certain other ingredients which might cause certain acid-base imbalances.
Yes.
So so as long as it's all in moderation, I don't think it's going to do any harm, and probably do some good as well. Yeah, absolutely.
Yeah.
Yes,
and if someone get COVID-19 rat positive, contact people with her, took rat after 5 days from last day of but they got negative. 10 days, one of them got PCR positive, CT value 28, other 2 get PCR negative. What is they meant by these values? That's a very good question, actually, right? So this is what I was describing. So someone has got positive rat, so that is definitely he is infective at the time, and then contact rat has been done at day 5. For the other people, obviously it will be negative, because even probably they were in the incubation period, the contacts at that time, and that is proven. Because in the early stages, as I told you previously, rat will be negative in the incubation period and the early disease stage when the virus is smallly replicating. And at the last day of contact, after 10 days, they got positive PSR at the body was 28. So the contact is there. Now the PCR is 28. And in between, there have been no symptoms. And most likely, this is early COVID disease of these patients rather than late. Now, even the CT value of 32 or 40 or 34, I will interpret it as early COVID disease in these patients. So if you want to be certain, I will be keeping them under observation. And obviously, I might arrange for a repeat PCR as well. So I think that is the answer for that question. So that is a very good question that is practically highlighted the problem. Contact is there. Yeah, the rat positive infective person. Day 5 contacts negative rat. Obviously, it will be negative. They were probably in the incubation period. And then at around day 10, PCR is positive. After the rat was negative, right? But at day 10, the CT values are very high. So most likely these were early disease patients. And if you repeat the PCR in about 48 hours, you might see that the trend is rising, right? Vitamin D, we have answered. Pregnant mothers, I think we have to discuss it. I will go on to one slide that I have to discuss. And how can we investigate pregnant mothers when chest X-ray is contraindicated? The answer, whether it is contraindicated, no, chest X-ray is not contraindicated. The background radiation that you can get with a chest X-ray is about 3 days, exposing yourself to sunlight. So that is the amount of radiation that the child will get after chest X-ray after a shield. But the most important thing is that if it is indicated, you have to take, but always you have to balance the risk and the benefit. In a person who doesn't have respiratory symptoms, saturation is normal, a pregnant lady, lungs are completely clear, there is no walking desaturation, I will never take a chest X-ray. That is not indicated. But if this mother is having symptoms, the saturation is about 92, 94, patient is tachypneic and the patient is needing an X-ray, I will not hesitate to take a chest X-ray. No, else I will even go for a CT chest as well, right? So basically, I think it is it is not contraindicated. You have to know exactly when to do the X-ray, and your threshold to do a chest X-ray in a pregnant lady should be higher than in a normal person, because even the children are precious. you have to be careful about unnecessary exposures of these patients. Aspirin, I think we have talked about.
Yes, yeah, absolutely, Neranjan. Yes,
Yeah.
just to add to that, it's very important for all the general practitioners to understand that chest X-rays are not contraindicated in pregnancy. Not only in COVID, even for TB.
Yes.
Any
Yes.
mother who is having cough for more than 2-3 weeks, if you suspect and no adequate weight gain as expected in her pregnancy, please do a chest X-ray. This might be TB, and you get more benefits by doing it than harms. And as Niranjan very correctly said, it's just like about 3 to 4 days of natural radiation that you get from a chest X-ray. And generally, by 20 weeks, the neurological development is done, and after 20 weeks, generally chest X-rays are not going to harm the baby. And of course, we have done a lot of HRCs.
Yes.
We have delivered. We have by section about uh, five mothers in the late 20s, 28 to 30 weeks. We have done seizures because they developed acute respiratory distress, and most of them we have done HRCTs also, which helped us to guide the management. So I think yes. So in the correct setting, we have to do. Yes, thank you.
Yes. And that's a beautiful question. I'm really thankful to Dr. Ruwana Siri Senadipati for having this question. This is a very practical question. Is it advisable to have a pulse oximeter as a household item? Can it give wrong readings and have wrong calibration, leading to misinterpretation of results and cause unnecessary hospital admissions? This is a very good question, because pulse oximeter, we have to know the mechanism of how the pulse oximeter reads the oxygen saturation. It uses infrared light, and then it interprets the what you call this the light that is coming back. And before interpreting the pulse oximeter, the important thing is you have to remove any nail polish or any other cutex or anything, especially in a female, from this thing, right? And the second thing is you have to put the pulse oximeter in and wait for about 10 to 15 seconds before getting a reading. Don't get the reading after the first 1 or 2 seconds, right? Because you have to. And the third thing is, this pulse oximeter should have a pulse meter. That means it should show the pulse wave, right? Whatever the method, it should show the pulse wave. So what we should do in a pulse oximeter is, if you want the correct reading, clean the what you call this finger properly, remove any coloring. Second thing, put the pulse oximeter appropriately, keep it without any tremors in an appropriate way, see the pulse wave, allow the pulse wave to come for about 5 or 6 seconds, and then go to the reading. And you might see that after, sometimes when you put the pulse oximeter, the saturation starts at 98 and then slightly reduce and reduce and reduce and reduce. So we should have to wait until the final reading is achieved. So at least about 3 or 4 seconds, this reading should be there. Then you know that this reading is most likely correct rather than wrong. So removing the coloring, nail coloring, putting the pulse oximeter, observing the pulse wave for about 10 seconds, allowing the value to be stabilized for about 3 to 4 seconds. That is the most important thing before reading. And always remember to look at the pulse rate as well. And sometimes what I do is I usually palpate the pulse and see whether this pulse is the same that is interpreted here. Because if you have a fast AF, you might sometimes you might not get the adequate amount of pulse volume here, and you might interpret it as a bradycardia sometimes. So anyway, that's there. And the other important thing, especially if you are doing a walking desaturation or the exertional desaturation, you have to remember that blood to come from the lung into the periphery, it will take some time. So sometimes what we do is we usually ask the patient to walk, and after has finished walking, we measure the value and then put it down, and that's the normal value. That is not the way. You should allow the patient to wear the pulse oximeter for about 30 seconds and then look at the value to see whether again there is a desaturation. Sometimes it might rise, and then it might drop 1 or 2. But if you ask the patient, keep the pulse oximeter for some time, then you will get the correct value. So that is the most important techniques that we have to use, not getting the proper value. Regarding the quality of the pulse oximeter, I think we have to have a very good tight regulation about the pulse oximeter type. So what I usually do is, if I'm suspecting that this value is not wrong, I will put it into my hand. Hopefully that I'll have a normal saturation, I'm hoping. So then if it gives a normal value about 96, 97 in my hand, most likely it is the normal value. So then I check it in the patient. So that is the most important thing. If you correctly read the pulse oximeter And if you can, before you give the patient the prescription, you can check the type of the pulse oximeter yourself and then see whether it is correct or not. And then I think these unnecessary admissions might not be there. Can somebody die with post-COVID syndrome again? Yes, that is totally there. Now, as Dominda said, the patient might be discharged from hospital after treating the patient, and then later, as you already know, any patients with viral damage, we have seen this in new influenza as well. Any patients who had primary pneumonia, viral pneumonias in the lung, they are prone to get secondary bacterial pneumonia, and especially these patients in the hospital get dexamethasone and immunosuppressive therapies in the hospital, and they can get severe pneumonias if even after being discharged. And some of them, we have seen that they develop fungal infections as well, right? That is a known fact, right? So we have a lot of patients who are being galactomannan positive at around day 17, 18, after, sometimes even after getting discharged or while in the hospital. So yes, post-COVID pneumonia, secondary bacterial, fungal pneumonias are it is common. It is not uncommon, and it is common definitely. We look for them before sending these patients home, and we usually do a CRP, do a repeat chest X-ray before we send the patient home. But unfortunately, sometimes when they go home after about 2 or 3 days, they can develop a pneumonia. And what we see here is now, earlier in influenza, what we have seen is the most commonest organisms are gram-positives after pneumonia, after influenza, like Streptococcus pneumonia and Staphylococcus aureus. But here, what we see is most of them are gram-negatives or fungal infections. So yes, that is when the vaccination come after getting the infection, we have talked about it, about silent hypoxia, COVID speed and MEDT. How about Sinopharm? I think we have talked about it. Vitamin E, we have talked. Pregnant mothers, we have talked. Right. What if the patient get antigen positivity continuous after 14 days after symptoms? Can you explain? I think, Duminder, it's very common, isn't it? Right.
Yeah, so
especially moderate to severe patients, I think we can get a rat positivity even after 21 to 30 days.
Yeah.
So, and we have to consider them as infective, and we should not move them to a normal ward. Okay.
Yeah, so the recommendations for from the national guidelines say only if the patient is immunocompromised to go for RAT. Yeah. Otherwise, you just go by the day and you discharge the patients. Yes. But there are a lot of institutes, especially these governments and all these these occupational institutes where they do RAT before taking the patients in, and some patients can get positive, so it's difficult to interpret. PCR, of course, can get positive because of the viral particles, but if the RAT positive, then we have to be a little bit scared. Sometimes it's very difficult to explain. Our microbiologists, they are not very happy when we ask for repeat investigations after patients getting COVID.
Yes.
Yeah, but at the community, they do these things. Yeah.
Yes. Absolutely. Right. So about the thrombosis risk about the Moderna vaccine, some of these vaccines have actually shown to be thrombogenic, especially the adenovirus-based vaccines. And especially about Moderna, if I remember correct, less than 40-year-old females, Caucasian females have been having a higher risk of thrombosis. So yes, there is a risk of thrombosis in certain vaccines, especially the adenovirus-based vaccines. But I think the risk of having severe disease outweighs far more than having the thrombotic risk, especially in the adult group. So I think we have to continue the vaccine at the same time, right? So I think, Tuminda, we have talked about the
So the last question, they say, can a patient get COVID twice? Yes, it's possible. Yes, if so, what's the time gap? Generally, natural immunity lasts for about 3 to 6 months. Generally, about 3 months. So after that, of course, it's possible to get COVID. It's not uncommon. I think we have covered them, right, Neranjan?
Yeah, and just give me about 2 minutes to describe this HRCT. It is very close to my heart. This is actually now, because we were talking about pregnant ladies, and we were planning to discuss about pregnant patients as well. Now, this is actually a HRCT of a 33-year-old pregnant lady, mother of 2 children. This was her 3rd child coming to our hospital with severe hypoxemia. Now, unfortunately, this patient came a little bit later, about day 6. So that highlights the importance of bringing these patients as early as possible into the hospital. And you can see that almost 95% of the lung is completely involved and distressed. Also, this patient was managed at the HDU. We were starting NIV. We didn't have to intubate. We gave tocilizumab for this patient, but unfortunately, even after tocilizumab, the lung was completely wiped out without a significant problem. She was needing oxygen, about 60% to 70% of oxygen and BiPAP treatment for about 4 to 6 weeks. And now the nice thing is that we were able to actually, so we started, the patient was treated with steroids, and we were able to treat her appropriately, and we were able to bring her to a ward over last Thursday, I think. Now she's on 3 liters of oxygen, and it's really happy to see these patients improve, isn't it, Duminder? Right? And we didn't think that this patient would survive, but it was a beautiful thing. And so the importance about pregnant women is that they can have severe disease. So we have to identify them early. We have to identify them early and refer to appropriate treatment as early as possible, right? And this is actually this is our team at Rathnapura. I know that most of the hospitals are like this. This is around 11:15 p.m. in the evening. This is about that pregnant lady. This is our consultant obstetrician. We have 2 anesthetists here. One senior anesthesia, Dr. Vadigaratha, Dr. Indika, myself, and Kapila. We were the BOG. Now this is the HDU we were able to build up in Rathnapura Hospital. We now have a 16-bed negative pressure ICU, but at the moment we are functioning 5 beds as intensive care and about 5 to 6 beds as HDU, high dependency care, where the BiPAP people are there, and the high flow nasal oxygen with the monitoring and everything. So this was built up newly within the past 1 year because of efforts of everyone. And I know that most of our hospitals, our colleagues, our physicians, the respiratory physicians, our anesthetists, intensivists, critical care physicians, microbiologists, administrators, everyone, and actually doing a huge work. Our medical officers are doing a brilliant job. We have a roster where voluntary medical officers come into work without any hesitation, going inside the COVID wards and doing their duties. And we also go in without hesitation when the need arises. In daily basis, most of our consultants are doing a rotationally ward round inside the COVID wards and in the ICU. Our critical care and intensive physicians are doing ward rounds without any hesitations. This throughout the Sri Lanka, I know the situation is like this, and these are the nursing officers who are in looking after. This is at about 10:30 p.m. in the evening, night. So they are now the final side. I have put it like this because now COVID has gave us a lot of things. I think it has been a challenging disease, but it has made us together, right? And we are facing this issue as a team in most of the instances. And I think this team effort is the one that we see as improved patient outcomes. When we see a critically ill, bad patient who was, struggling with their lives, coming to the clinic walking, I think that is the greatest reward that we have in our patients. So the most important thing from the general practitioner view is that we have to prevent people going into the ICU and critical care. So for that, I think the take-home messages that I would like to give is that first thing, enhance and improve vaccination. When they ask about vaccination, don't be hesitant. You can read about all the guidelines and be confident about themselves. And tell them that this is not the efficacy of preventing the infection. We will get infected from one way or the other, but preventing the serious deaths and the hospitalizations are the most important thing. So get a vaccine without delay, get the 2 doses as early as possible. I think that is the best advice as a general practitioner and a medical officer that we can give when we are looking at the pandemic at the moment. Second thing, identify the people who are coming to you early and identify or diagnose COVID using appropriate diagnostic tests which are available. And then high-risk patients, we have to identify early, refer them to hospitals for further management without any significant delay. That will prevent deaths, and that will definitely prevent unnecessary hospitalizations and comorbidities. The third important thing is that we have to be proactive in treating and identifying people with post-COVID, because you will be getting a huge amount of patients with post-COVID syndromes. Talk to them, because they are very close to the general practitioner than to us. So they will be coming to you with significant main problems. And sometimes you might think that they are sometimes malingering, but they are not. Remember, these are genuine symptoms. So please address them appropriately. And if you have any suspicion, please be free to refer these patients to the hospital so that we can further investigate these patients down. So together, I think we can, and we have actually to a certain extent, even though COVID has given us multiple challenges, to a certain extent, we were able to withstand these challenges, and we were able to serve our people, and we were able to save critically ill patients. And especially in the post-COVID clinic, when we see these patients who were white-out lungs coming back in about 2 weeks' time with a clearing lung, saturation is improving, they are happy. I think that is the best reward that we can have as doctors. And I think that is the reward that we usually have on a daily basis. And that keeps us going, even being sleepless even at nights. And I think as clinicians and doctors, I think we should be happy about what we are doing in the country. Okay. And thank you very much, I think, Dr. Kudagammana, Dr. Wasana Kiridena, for giving us the opportunity to present this about this important topic. And at the same time, Duminda, I think you have been a wonderful colleague throughout, and we have many shared interests, I think, right? And it's really nice to be having a discussion, rather than what I wanted to do was, rather than have a presentation, to have a discussion type of this thing, so that people will be more interested rather than going through slides. I thought that this method was more better, and I think I couldn't ask for a better moderator and a colleague than you for this. And thank you very much. Even we have a very interesting match going on. I don't know whether we have lost it at the moment, but anyway, thank you for about 120 or 30 people who joined for this discussion, and hopefully the discussion will be available through Facebook by the PeMSAA website. Thank you very much, and good night. And over to you, Duminda and Dr. Kudagammana.
Thank you, Neranjan. Yeah, so it has been a very interesting discussion. So in fact, Neranjan called me around 6:30 and said that both of his computers are not working. Said that he has lost all his slides. He can't recover them. Shall we postpone them, because otherwise he will be talking and people have to look at his face. So I said, knowing Neranjan's ability to hold an audience for a couple of hours or even more without any printed or written materials, I flatly refused. And you see the result. It has been a very lively discussion. And I suspect now Neranjan was planning to watch the match by postponing this webinar. Right. So anyway, thank you very much, Neranjan, for that very lively and very informative discussion. I'm sure that our medical students and our general practitioners and also us, we all learned quite a lot from this discussion. It's very helpful, and so thanks once again. And you have been always very helpful with the PeMSAA activities, and you have been you are a council member. So, and also not only PeMSAA activities, any educational activities, Neranjan is one of the persons who always volunteer and step forward. So thanks again for this wonderful presentations and discussion, Neranjan. So to conclude the session, I would like to invite Dr. Wasana Kiridena, who's the main person behind the scene, who's the main chief organizer of this session. And she's been a past secretary of the PeMSAA, and also she's the social secretary and probably a future prospect of our president for the PeMSAA as well, I suppose. Over to Dr. Kiridena.
Pampering. Okay. Right. Thank you, Duminda. I won't make much time because we have already consumed 2 hours, but a very fruitful discussion. So thank you very much, Dr. Neranjan Dissanayaka, for your wonderful presentation. Amidst of your, busy schedule, you are a very dedicated chest physician, heavily involved with COVID management. However, with your first-hand experience, the session generated a lot of questions and discussion, and both Dr. Neranjan and Dr. Duminda, our moderator, conducted it really well. I think it cleared off a lot of dilemmas and updated the knowledge of general practitioners. And actually, we are going to live with this virus for another significant period of time. So we need to create a dialogue between us, the physicians, or who are involved in the front line, and the general practitioners in the community, because most of the patients in the future will have to be served in the community with this long COVID syndromes. So, also this was the inaugural regional meeting. And I'm very thankful to Dr. Neranjan. Within a very short period of time, you organized this. And we are thankful for your team as well. You showed us how dedicated the team at Rathnapura Hospital are. So we'll be meeting again with more regional meetings. And I must thank our president, Professor Tushara Kudagammana, for having this in his calendar of events. And Dr. Duminda Yasaratna for moderating it so well and contributing to the discussion. And you also are very busy chest physician involved in the management of COVID patients. So I think all the entire audience was so lucky to have a discussion with two eminent people with first-hand experience. So thank you very much. And I must thank the enthusiastic audience as well. And I think with time to come, we might have to meet again on another platform to talk about long COVID syndromes.
Definitely, yes.
Exactly. Okay, right. So we'll conclude then, right?
Yeah.
So have a pleasant evening, all of you. Good night.
Good night. Good night.
Madam, small question.
Yes.
Is it okay to ask?
Sure.
As
Yes.
you said it's a entry of port is only throat.
Right.
So I have read all the mucosa, even the eye can contaminate. All the mucosa have ACE2 receptors where the coronavirus used to get into.
Yeah.
And my worry is why not the GIT part? Because I have read that ACE receptors are abundant in all heart, lungs, all vascular epitheliums, and GIT, and kidneys, all 5 areas.
That is really good. The Dr. Hussain, now basically the port of entry of most of the respiratory viruses are basically the epithelium in the upper respiratory tract, because they are basically getting entry through the nose usually. Right. So I agree that usually they can go into, especially after getting infected through the throat by swallowing the saliva, or very unlikely that you can get a huge amount of viruses through the mouth only, which is very unlikely, I think. But even when you have that, by the acidic environment of the stomach and the digestive enzymes, most of these viruses might be diluted and digested before getting attached through the GI tract. That is my postulation, because usually you don't get a huge amount of viral load going through the mouth. You might touch a utensil that was contaminated by the virus, and then you might touch your lip, and it is a very small amount that you can go. So usually the probability of the portal of entry of the COVID virus is, I think, still most likely is the nasopharynx, given that because it's an inhalation mediated virus going through the nasopharynx. And obviously, as you said, most of these cells, almost all of these cells, probably except the RBC, has AC inhibitors. So theoretically, yes, any cell can be infected and affected. So that might be the reason that you have long COVID or post-COVID syndrome or the complications, because any cell in our body, including the brain, the neural cells, the muscle cells, and the GI tract as well, can be entered into by this virus after having viremia, and then can be infected and destroyed by this virus. So I think that is the most likely possibility here.
Okay, thank you very much. I got it.
Okay.
Right.
Okay. Right.
I had this doubt from since lot of time back.
Yes.
You only you with rational law, even acceptable for me at least. Answer. Thank you.
Yeah, you have to be skeptical always, Dr. Hussain. That is the way that you have to be. You have to be always inquisitive, and we have to learn from whatever the sources that we have. That is a very good question, I think. Okay.
Thank you very much.
Have a nice day. Okay, bye.
Same to you. Bye.
Right. Okay. Then thanks, Neranjan, again, and thank you everybody for participating.
Yeah.
So we'll call it a day. Okay then.
Yeah. Okay. So
Good night.
hopefully
Good night,
we'll enjoy the rest of the match. Hopefully we are winning. Okay. Bye. Right.
Okay. Then. Good night.
We have lost already.
No.
No. It's raining. It's raining.
Okay, so we were saved by the rain then, most likely. Okay, thank you, Dr. Dissanayaka. Have a nice day. Bye.
Okay,
Bye.
bye.
Good
Thank
night.
you. Thank you, Neranjan. Okay, bye.